Hi, I'm Dr. Jared Gardner. I'm here today with my awesome dermatology residents and Dermpath fellows, and we're going to do some rapid fire unknown Dermpath cases. Thanks to my fellow Dr. Connie Fiore for helping me pick these out yesterday. And the residents have not had any chance to preview these, so it's going to be totally cold. All right, and hopefully not cold in like the negative sense, well, anyway, let's do it. All right, case one. Let's see what you guys think about this one. And I wish I had a digital slide of this to give you the real low power. No skin here, right? Just pink fibrous stuff and some fat. Any ideas what this is? It doesn't look real exciting from low power, but once you've seen it a couple times, you might have an idea of what this is. That's a great thought. That is not what it is, but that's an excellent thought whenever you see collagen intermingled with fat. Definitely should be on your differential, and usually it's going to come without epidermis attached. Other ideas? Another great thought. Okay, I may leave some of the wrong answers in the video because these are like really good differentials. Yeah, that's another thing that's going to give you intermingled pink and fat together, and there you're going to look for, of course, the little mesenchymal, immature mesenchymal nodules or immature mesenchyme, which can be a little hard to see at low power. So, but that's another one that's this is very much actually, the arrangement is like fibrous hamartoma. It's a kind of a hodgepodge of fat and fibrous stuff mingled together. That's another good thought too, because it also can trickle into fat. And while we're at it, we could say diffuse neurofibroma. That's another thing that can be pink and spindly and intermingle with fat. So you guys have a great differential of all the things that can mingle with fat. And I would say that most people, even probably people who have seen this entity before, probably don't recognize it at 2x magnification. So I was being a little unfair, but I thought, let's just try. I finally got to the point where I usually can think of this, but now probably you guys will be able to figure out what this is now that I show you the feature, the key. Oh, I liked it better with the condenser. What are these? These little blobs here.
Those little balls of elastin, like an elastofibroma dorsi.
Very good. That is exactly what this is. This is Elastofibroma dorsi. You're right. And these are, I think, not a really fair thing to quiz derm residents over or to have on derm exams, because this is an entity that, in my experience, has never occurred in the skin. Although there have been reports of them in unusual locations, I've just never seen one. The only place I have personally ever seen these is underneath the tip of the scapula, between the scapula bone and the rib cage. So way deeper than any of you should be going with your shave biopsies, okay? I mean, that's pretty aggressive if you're getting down to rib cage, all right? So these are things also that often are not removed because orthopedic surgeons recognize these on imaging. They have a very distinct appearance usually. They oftentimes are bilateral. There's debate over what they are exactly, but I think the current belief is that they're probably a weird reactive process from kind of the movement of the scapula tip over the rib cage. It kind of produces this reactive buildup of these unusual distorted elastic fibers. And you can see it really, I mean, you don't really need it, but it's very beautiful if you do an elastin VVG stain. And I meant to pull one up and forgot to, but I have a video on my YouTube channel if you want. I've got a really beautiful stain of it in there. And it has the elastic fibers have kind of a, when they're cut in long section like this, longitudinal section, they kind of have this kind of caterpillar shape, like kind of fuzzy, like a little caterpillar. And when you cut them in cross section, they look like this. They kind of look like little flowers or florets, like so. This kind of beaded or jumbled, kind of fuzzy bordered elastic fibers, and they're much thicker than the fibers of some of the other things, like the disorganized fibers that you can see in penicillamine associated diseases and stuff like that. Those will also, or pseudoxanthoma elasticum, also have disorganized elastic fibers, but those look different. They're much thinner. These are big, thick, fat elastic bundles. and they're intermingled, of course, with the bright pink collagen. So elastic stain is beautiful for this, but usually, again, these are recognized on imaging, so I feel like they don't get removed usually for diagnostic purposes. Sometimes they get removed because they're, symptomatic or something like that, but I don't end up seeing them very often because, again, I think most orthopedic surgeons see them on MRI, they know what it is, and then and they don't usually do anything aggressive about it unless it's a problematic lesion for the patient. So there you can see the bundles. Now let's go back up to 2x. You really can't, it's really hard to see the bundles here, but you can kind of appreciate that the collagen's kind of distorted. It's got some bluish, almost mucin or myxoid stuff to it. It's really hard, though, to see the bundles there, but I think the low power of this kind of bland pink intermingled with fat always makes me think of this, but I loved all the differentials you guys brought up were all things that from low power are appropriate to consider. So Elastofibroma dorsi. All right. I'll show you the whole lesion here. We're lucky we've got like the whole lesion on the excision rather than just a little biopsy, which could make it a lot harder. Does anyone know what this is from low power? And by that, I'm guessing you mean
Papillary, eccrine, adenoma, or tubular apocrine.
Yeah, exactly. And I love the combination of those together. Papillary, eccrine adenoma, and tubular apocrine adenoma, are sometimes taught as two different entities. I personally do not reliably know how to distinguish them. I guess if you see apocrine little snouts, you can say tubular apocrine adenoma. If there's more papillae, you can say papillary eccrine adenoma. They have an awful lot of overlap to me. Even when I look through my archive teaching collection, things that in the past have been labeled and I've received from other people as either papillary eccrine adenoma or tubular apocrine adenoma, when I look at them, I'm like, these all look the same. So I don't know. Someone out there may be smarter and better than me and in Dermpath, we love to split things, especially adnexal tumors. Like we love to split when it matters the least for patient care, I think. In any case, recognizing this is important, whatever name you give to it, because it's a benign thing that could potentially cause some confusion with malignancy, right? What we have from low power is a bunch of tubules, right? Individual little tubules with duct or gland or cystic space in the middle, and they're kind of scattered about haphazardly in the middle, but as you look to the periphery, they don't really infiltrate. I've seen ones that kind of trickle out a little bit, but you don't see trickling way far away from the tumor like you'd see, in a microcystic adnexal carcinoma or something else malignant, okay? Or if this is I've seen these occasionally on the hands or feet, and you have to be really careful there to make sure you're not missing digital papillary adenocarcinoma. In that site, unless it's definitive, I often would like to see the whole lesion just to make sure. But they are kind of jumbled together in the middle, but at the edge you can see they kind of make a nice nodule. In this case, kind of similar to syringoma, you can see, look at the collagen out here of the normal dermis. You can see individual reticular collagen bundles. Here in the midst of the lesion, the collagen becomes much more dense and sclerotic. Syringoma does that same thing. The difference here is, some of these look kind of tadpole shaped like syringoma. They're just much more dilated than most syringomas that I've seen. And also when you look into the lumens, you begin to see that the lining of these little ducts becomes more proliferative and complex. It's not the thin, double layer cuboidal lining or columnar lining that a syringoma would have. Instead, you have these kind of little arches and branches and little tiny islands and papillae that are pushing into the lumen. And papillae, papilla means a finger-like projection, but when they're cut on cross section, sometimes they're just going to look like a little tiny island. And these are bland. There's no atypia here. Also, if you look at the ducts, you can see that they have like they have a double layer lining, right? Just like normal sweat ducts do. Let me find out. I guess that one I had was the best. Some of these are very atrophic lining, so it's a little harder to see. There, you can see the inner lining here is kind of columnar cells. And the outer lining is a little more cuboidal, that little basal or myoepithelial layer, recapitulating what you see in a normal sweat duct. So papillary eccrine adenoma, or if you like tubular apocrine adenoma, but I like to combine those two as one. And there's inspissated or kind of dried up condensed sweat secretion in the middle of these, as can happen in a variety of different adnexal things. In fact, anytime you get sweat ducts that have kind of blockage, even in a reactive setting, you can get this sweat buildup in there. And there's some more little papillae right there. So bland, and from low power, relatively circumscribed, although in the middle, pretty haphazard looking. Like if you just had this, you see ducts and glands everywhere. And regarding microcystic adnexal carcinoma, MAC, usually those occur on the face. This entity, I believe, is more common on the extremities. At least the ones I've seen have been on the extremities. And in my experience, MAC usually has, the ducts are kind of subtle. I've got a couple of videos about microcystic adnexal carcinoma if you want to check them out. But in my experience, it's often you have to really hunt around for the ducts and only find them deep down, whereas this entity has obvious dilated ductal structures everywhere, just like a syringoma. So I feel like that's one like simple way that usually will help you to sort out that differential. All right, excellent. Number 3. Okay. What's the main problem or pattern that we're dealing with here from low power? This is pretty hard.
It looks like maybe a subepidermal split.
Good. There is a split. Very, very astute, Dr. Pitch. Just what I'd expect from a future Dermpath fellow. All right. Any idea what's causing the blister here?
There's a lot of vascular congestion, so I wonder if it's like almost secondary to like necrosis or thrombosis.
Very good. Yeah, this is a crucial thing to recognize, and this is a really important finding, that this is ischemic change, right? The epidermis is looking not totally dead, but definitely not happy, right? It's starting to kind of wither away and begin to die because of ischemia and loss of oxygen from loss of blood flow. And you can see that the nuclei are starting to kind of get pale. The background of the cytoplasm is kind of getting mangled a little bit. And then as it dies, it's breaking away and splitting. So it is a subepidermal split, but it's due to the death of the epidermis. And then over here, you can tell the epidermis does not look super excited either. Wait, what's that?
And those little hyphae.
Oh, yeah. These are fungal hyphae, and not dermatophyte hyphae. Now, obviously, speciating fungal hyphae is a very tricky game. Sometimes you can get some ideas based on the shape of the hyphae or where they're located. Here, these are on the surface where you'd expect a dermatophyte or something to be, but they're not just on the surface. Look, I'm going to try to move this without, no. Look, they're right here too. They're here, they're there, they're everywhere. They're these open kind of ribbon-like hyphae with no obvious septation. And again, I was always trained to not try to speciate hyphal fungal infections on H&E, although I've heard some really great people like Dirk Elston, who I really admire and look up to, say that sometimes you can, and that actually can be really helpful. So that he said that at like ASDP meeting last year, which really kind of shattered my worldview a little bit. So I'm still trying to mentally and emotionally adjust to that. But his point was that it can potentially help in patient care. But I do still feel that the only way to really definitively know in a lot of cases is culture or molecular. But in any case, this ended up being, well, if you had to guess, what would you think that species this might be? Let me show you a more characteristic area. Here it is, all up in the vessel. Broad, aseptate, ribbon-like. See how it's just kind of folded over itself like a little ribbon? Yeah, this is one of the zygomycosis group. This is the classic feature. The thing is that we have to remember all the fungal hyphae descriptions are usually based on mycology lab, the way the fungus looks growing on an agar plate. When it grows in tissue, it can really look different, especially if the patient's already received antifungal treatments. I saw a case once where I thought, oh, I think this is probably going to be something mucor-like, and it looked kind of ribbon-like this. Nope, it was Aspergillus niger, but it had been treated with amphotericin, which distorted the shape. So it was one of those times that taught me that it really is kind of dangerous. if you don't know, to be definitive about the species. So here, yeah, that we have, this is angioinvasive fungal infection. And in this case, this was Rhizopus, which is related. Mucor, Rhizopus, Absidia are all in this same kind of group of zygomyces kind of fungal infections. So you'll note here there's a little inflammation here, but if you look from low power, really the rest of it doesn't have much inflammation, even though it's got loads of fungal hyphae growing everywhere, growing in the vessels, through the vessel. You can see it right here, penetrating out of the vessel wall. That's classic. This is classic angioinvasive fungus. It grows in the vessel, often with congestion of blood or fibrin thrombi, which is what's causing the ischemic change. And then it grows across the vessel wall here and out. So I don't know the history, but I would say almost certainly this is probably a bone marrow transplant or other severely immunocompromised patient, because they've got fungus everywhere with no granulomas, almost no neutrophils, so they're probably neutropenic. And I think that's often the case, that in these patients, they'll have this very like pink appearing biopsy that just has blood and dilated vessels and doesn't have much inflammation, so it doesn't make you think infection at first, and then you go look and there's fungus everywhere. So here on the H&E we can see the fungus, and the dilated congested vessels always should make us think maybe there's fibrin thrombi somewhere else, and in this case you can see some fibrin like right here. And it's important to tell blood and fibrin apart, because every once in a while you can see a congested vessel just coincidentally. But there's the blood, red blood cells, and here's the more smudgy, kind of lighter pink colored fibrin. So the fungus often goes hand in hand with fibrin thrombus, and there's more fungus, more fungus, more fungus. And in this case, the fungus has grown out all over the dermis and has even penetrated through the epidermis and started to grow on the surface, again, because of the basically lack of immune response from the patient. So very serious Dermpath emergency that's important to recognize. And recognizing the ischemic change is crucial because, of course, there are a variety of things, thrombotic vasculopathies, cryoglobulinemia, a lot of other stuff that can cause that ischemic pattern, but fungus should be right on your list. Calciphylaxis also, and I've got videos about that. Good work. What a great case. Any takers?
Like a blue native, EPN.
That's a good thought. Pigment, down deep. Now, as we get closer, what color is this pigment?
Black.
Black. So, what do you think now?
So, not human.
Not human. Excellent. Human body does not make black. It doesn't make true black. All the things, no matter how black they look clinically, are brown under the microscope, right? And we can make other shades of color under the microscope, though, but black is not one of them. Black is exogenous. If it's truly black, it's exogenous substance from outside the body, carbon or something else, or metal or something like that. That's been my experience, at least. So here's what it looks like up close. And look what's we got. Oh, I got to show you this. Okay, I'll come back to that actually in a minute. Here's a little bit better. In addition to this, what else do we have here with this black pigment? Absolutely. We got histiocytes, multinucleated giant cells trying to chomp this stuff up, trying to eat it. So we've got some sort of exogenous foreign material here. Any guesses on what this might be? And we can't always know. I see lots of times where there's foreign material and I never get a history and I never know. But this one I think has a pretty distinct look most of the time.
Maybe like a traumatic tattoo?
Yeah.
So deep. I don't know
Yes.
exactly what's causing the pigment, if it's like metal or
Yes.
pencil.
This is pencil. Good job. Graphite. Well done. Yes, this is graphite tattoo, and it is indeed traumatic. Someone got stabbed with a pencil, and pretty deep stab by the looks of it, and a bunch of graphite got left behind. Graphite is black. It's carbon, right? And it usually is big, chunky, angulated fragments like this. And let's see if it polarizes. I've found variable success with polarizing this. I feel like sometimes there's little bits that polarize. It's also hard to show on video polarization. Oh, here, that's light from my window. Now, see, this one doesn't have much polarization. Oh, there. And I can, oh, if I just cover it just right, you can get it to work. See, not all of it polarizes. Can you see that? There's little tiny stippled bits that polarize, but big chunks of the black don't. So I don't know exactly how pencil graphite is made, but I suspect that there may be different formulations and maybe it's mixed together with something. But I feel like a lot of times you'll find little tiny specks of polarizable stuff, but not the entirety of the substance will polarize. There may be someone out there who's like a crystallographer who knows more about all this than me. I'm just a simple dermatopathologist. But in any case, I would say the chunky black angulated look is a pretty strong clue for graphite, although I've seen some that was much more fine. So again, I suspect there's different ways that pencil graphite is made. And if you're lucky, you'll find a chunk of wood with it. I've occasionally seen that, a little bit of wood from the pencil left in the patient. You see the plant cells there. Pretty awesome. But otherwise, if I didn't know, I would just say that this is exogenous pigmented substance that's got a foreign body reaction to it. Now, the thing that I was excited about up here, let me show you. If I can find it again. I think I can. There it is. What's that little cutie right here? It's a little hard to show, unfortunately. These are sometimes hard to see. It's a little star-shaped bit of collagen. That's an asteroid body. See that? It's like a little tangle of collagen inside a giant cell. And you know, people often teach asteroid bodies as like the buzzword, and I've got some nicer pictures of these that I've put on Twitter before. You can go if you Google asteroid body at JMGardnerMD, I think Google Images will bring it up for you. Check it out. But the asteroid bodies, which are taught about in sarcoidosis, I see them way more often in foreign body granulomas than in sarcoid. Probably because foreign body granulomas are more common than sarcoid. But in any case, so if you see foreign body reaction, go hunt around, and you might be surprised by a cute little asteroid body. They're so pretty to look at. I like them. So foreign body from graphite. And you're right, at low power, you could definitely think of a pigmented lesion until you get close enough to see that it's black, and then you realize, nope, not melanin. Melanin's always brown. Okay. Oh, let me clean the slide. Now, I think this one's a bit more challenging. Any thoughts? Let me give you some history. Patient has multiple 2 millimeter erythematous kind of scaly papules on the legs. Clinically rule out pityriasis lichenoides chronica. That's the clinical impression. And this is a disease that I still just only recently have started to wrap my head around and recognize. I've always struggled with it. So if you struggle with it too, no problem.
Flegel?
Nice. Flegel's disease. Good. Yeah, so this one, I finally am at the point where I see it and I'm like, that looks like Flegel's, but I have trouble remembering why. And that's because it's a mixture of kind of relatively common patterns. But the three main patterns that the clinical, like I told you, they multiple scaly erythematous, little papules on the legs usually. But microscopically, what you get is a kind of a triad of hyperkeratosis, this real dense, compact, usually ortho. This one has a little para, but dense, thick, compact hyperkeratosis. Then atrophy of the epidermis. The reedy go away. The spinous layer gets really thin. And then underneath it, you get a lichenoid band of inflammation. Well, it looks lichenoid at first, but when you go closer, a true lichenoid is an interface dermatitis, right? So you should have vacuolar change with dying keratinocytes in addition to a band of lymphs. But here we really don't. We have a band, but the interface is nice and clean and smooth, and there's really not any dying keratinocytes. So hyperkeratosis, again, this one breaks the rules a little because it's got para with it, but this fit really nicely clinically for Flegel's. And then atrophy of the epidermis, and then a band of lymphs without much interface change. And you can see even on this shape that even without the history, this is a small discrete papule because you can tell it's normal on both sides of the lesion. I find that helpful when you see a change in the middle of the biopsy and relatively normal skin at both edges. Usually means you're dealing with something small and papular clinically. So this is Flegel's disease, hyperkeratosis, lenticularis perstans. All right, does anyone know where we are in the body from this power? How about now? Mucosal, good. It's got that pallor at the top, lack of a granular layer, no real stratum corneum, no adnexal structure, so squamous mucosa, good. And what's this down here? Skeletal muscle. So where do we see those two things together? The tongue, good. Yeah, this is tongue. To see a whole bunch of skeletal muscle right under mucosa, usually going to be the tongue. So they've done a pretty generous tongue biopsy here. I don't really see much inflammation, like for a lichenoid thing. I don't see much atypia to make me think of dysplasia or cancer. Although I still struggle with mucosal atypia in the mouth. I feel like oral pathology uses kind of a different set of rules for judging atypia compared to skin. See if I can get them in focus. It's really hard. There are some nuclei here that are kind of smudgy chromatin appearance. Maybe it's better. So this is positive for Epstein-Barr virus by in situ hybridization. So this is oral hairy leukoplakia, and this patient actually did not have HIV. A lot of times it's in HIV patients. This is something I've only rarely have seen biopsies of. Maybe it usually goes to oral path. But they basically have viral alteration of the keratinocyte nuclei with little inclusions. And I've got a little video of this on my channel that has a better close-up view of the inclusions. I still find this one of those things that I have to remind myself to think of, because, at low power, this doesn't, to me, look like, it looks more or less normal-ish. I mean, there's a little inflammation here, a little fibrosis, but otherwise, and it kind of, a ratty surface, but not a real distinct appearance from low power, but close up, the keratinocyte nuclei have that unusual look. And if you think of it and then do the Epstein-Barr virus, EBER in situ hybridization, then you can confirm the diagnosis. So oral hairy leukoplakia. And then, of course, you have to rule out HIV in that setting because that's often what the patient's in. Okay. What do we have here? It's a polypoid lesion clinically, right? Because you can see you can't really tell where the base is. And so depending how the sectioning goes, polypoid lesions like skin tags and other polyps, they often, get kind of distorted when we put them in for sectioning, and you often kind of get this very tangential looking section because they're rounded rather than, nice, flat surface structures. Does anyone want to take a stab from low power? Because with practice, you can recognize this at 2x. Very good, sir. Yes, Verruciform xanthoma. It's got a papillomatous verrucous, in this case, almost condyloma-looking architecture, and that's an important thing to make sure you don't confuse it with a condyloma, since this is not virally derived. But not only do you have papillomatosis, but down in the little cleft-like spaces, you have really dense pink parakeratosis. I know condylomas get a little bit of parakeratosis down in between, but this is like this bright pink, almost fiery-looking parakeratosis that you see here, right? In between. And so a friend online once taught me this, it's like a wart on fire. And I thought, oh, that's really great. It's kind of warty, but it looks blazing bright pink. And when you go closer, you can see that that stuff is parakeratosis, often with some scattered neutrophils, and there's no granular layer usually, or very diminished granular layer. This is abrupt transition from keratinocytes into this really dense pink keratin with retained nuclei. And then the next step is you go and look in the papillary dermis here, and what you see are all these foamy histiocytes, okay? Nice foamy, bubbly histiocytes here. And so these are kind of xanthomatous cells, and you can tell that they've got vacuolation of the cytoplasm with indentation of the nucleus, showing you that they're true little tiny lipid bubbles. And of course, these are not, the thought is that this is some sort of reactive xanthomatous cell accumulation related to the lesion, not evidence of anything to do with systemic lipid abnormalities. So are not associated with hypertriglyceridemia or hypercholesterolemia or anything like that. So these often occur, the genitals are a good site, anogenital region, and also the oral cavity are kind of, I think, the two most common sites, although I saw one like on the arm once. So they can occur at other places. And the one thing that I don't remember learning this before, maybe other people have brought this up, but I learned in practice, is that the top of verrucous carcinoma can have this kind of keratin pattern or similar. It can be verrucous and bland and have this bright pink keratin. And I saw one once that had a little bit of foamy histiocytes underneath, and on a superficial biopsy, it was from the penile shaft. I thought, looks like a Verruciform xanthoma. Thankfully, clinically, they were like, this is concerning, and the patient had, unknown to me, a history of something else that was concerning on a previous biopsy, and they excised the lesion, and it was verrucous carcinoma. But on a shave biopsy, initially, I thought it was a Verruciform xanthoma, actually, and I thought, ooh, that's scary. I did not realize those could look alike. And once it came out, it was clearly that's what it was. So I think on a big lesion like this, no worry. But on a superficial shave where you don't have a good idea of the shape of the lesion or the clinical, just do remember that those can superficially look a little similar. But on a test, this is Verruciform xanthoma for sure. What do you think? Yeah, very good. There's Paget's disease. There are atypical cells with pale cytoplasm here, and there definitely is edema, fibrosis, inflammation in the dermis, and that's a good pickup because sometimes this is a really florid case of Paget's, but sometimes Paget's disease can be a little subtle, and the presence of that inflammatory response in the dermis can make me think, ooh, especially if it's in the nipple or the anogenital region, go look closer at the epidermis, make sure I'm not missing some subtle Paget's disease. But here, let me try to turn it to get it right side up. Here you can see the atypical cells, abundant pale cytoplasm, their pagetoid spread up into the upper reaches of the epidermis and even into the stratum corneum. Right here, these ones, sometimes you'll find little mucin droplets, little droplets of bluish mucin, and you can use mucicarmine to highlight those if you want. And then sometimes they're obvious, like on this one, but sometimes they're a little bit more subtle. And then sometimes the cells are either single or they can make nests like this. And occasionally you can even have gland formation and see actual little glands or ducts trying to be reproduced. Because this is basically like an adenocarcinoma in situ of the epidermis. And the thought is in the nipple, these usually come from underlying breast cancer. That's the patient with patches. The nipple has breast cancer until proven otherwise. You have to go work them up. In the anogenital region, the most common one that I see is primary extramammary Paget's, which means it's of the skin, and we think it arises from some sort of sweat gland precursor cell that gives rise to this. But they can occasionally, in the anogenital region, have internal carcinomas like rectal cancer. I've seen it rarely with urothelial carcinoma growing out of the urethral meatus and onto the glans penis. So you have to, if it's especially near an orifice, you have to exclude an internal malignancy. But I feel like most of the cases of genital extramammary Paget's that I've seen are primary in the skin and do not have an internal carcinoma. Okay, so if you see something that looks pagetoid in the nipple or the anogenital area, it's Paget's disease until you prove otherwise. I saw a case a long time ago where the patient had Paget's of the scrotum, and they said, oh, that guy years ago had a melanoma of the scrotum also, and I was like, I don't think so. I never saw the old specimen, but surely it must have been Paget's that someone mistook for melanoma, okay? All right, the thing is that also Paget's, it has, just like squamous situ, squamous cell carcinoma in situ tends to have an eyeliner sign. Paget's can too. It can have a little layer of crushed, preserved basal layer underneath the tumor cells. And these cells, my favorite stain to highlight them is cytokeratin 7. CK7 is a pretty nice stain that usually stains them, with rare exceptions. And I've got some other videos about Paget's where we go into it more. Mucicarmine can be helpful again. And if you want to rule out melanoma, do a SOX10. If you want to rule out squamous cell carcinoma, you could do CK5, 6, or a P40, P63, one of those. And always look for invasion, because sometimes they do invade also. And we can tell here, even without the history, that we're probably in genital skin, because look at all the smooth muscle bundles. There's smooth muscle bundles everywhere. And smooth muscle bundles, when they're abundant, you always have to think of the genital skin and the nipple/areola. And usually the nipple areola has very large, kind of chunky smooth muscle bundles, and the genitals usually very small like this, and they often go really deep down into the dermis like that. So that's very typical of the labia or the scrotum, to have these multiple small bundles of smooth muscle. So extramammary Paget's disease. Okay. What do you think? Any ideas from low power?
You're wondering about leprosy?
Very good. Right away, this yells leprosy to me. Now, it doesn't always mean that's what it'll be, but we've got something where we can tell there's histiocytes, right? The pale cells here. The darker ones are going to be lymphs or plasma cells, but when we got collections of pale cells here, usually that's going to be histiocytes or granulomatous infiltrate, until proven otherwise. Like, well, from low power, my first thought's histiocytes when I see a bunch of pale gray pink cells in the dermis. And you can tell that they are aggregated here tightly. We don't know what they're around, but the fact that they're kind of tracking along in this elongated serpiginous pattern, or aggregated in round structures down here, they're tracking something. And usually that means they're tracking nerves and blood vessels. If you see granulomas tracking nerves, leprosy until proven otherwise. But I would say the same thing if you see granulomas tracking blood vessels, because guess what runs right next to a blood vessel? A nerve, right? So you may not see the nerve in your sections, but the vessels and nerves run alongside each other. I also feel like you can see periadnexal. I think this one actually had some, if I recall. Periadnexal, no, maybe it was a different case I'm thinking of. Periadnexal granulomatous stuff I often see in leprosy as well. So when we go closer, you can see that the histiocytes have abundant, kind of frothy, pale cytoplasm. And look, go one closer. It's a little hard to get to show. But what is that little round structure there with little crumbly, bluish, pink stuff in it? And there's another one down here. There's one. There's one. What are those called?
Cells with globi in them.
Yeah, good. Those are globi. And so those are all those little tiny crumbly aggregates inside these vacuoles in the histiocytes. Those are all going to be mycobacteria leprae organisms. You can see similar cells in other forms of mycobacteria infection. Usually, so if you had to guess which, or if you had to classify this, which type of leprosy would you put this into? Probably. There are different ways to classify leprosy, but is this tuberculoid or is this lepromatous?
Because if you're seeing organisms, it would be more on the lepromatous side.
Yes, good. But a lot of times we teach about tuberculoid, which has nice, really tight sarcoidal looking granulomas that track along and are serpiginous. But I often see this tracking along nerves in lepromatous leprosy. Also, this case was submitted to me through like a recut exchange, and they called this borderline lepromatous. I have to admit to you, even after reading about it, I struggle to understand how to put things into the borderline and indeterminate categories. I basically am a very simple, like kind of, it's either very few organisms and really tight granulomas with abundant, real dense pink cytoplasm that looks sarcoidal. That's the tuberculoid end of the spectrum. When there's globi and numerous organisms on Fite stain, then that's going to be towards the lepromatous end. Everything in the middle, I'll leave it to people that have experience with leprosy to sort out. Because the main thing, my understanding is the main thing for treatment is if it's posibacillary, which is on the tuberculoid end of the spectrum, or if it's multibacillary, and also what extent of the body's involved, that there are some differences in treatment regimen based on those different types. So here, look, you can see this is a nerve right here. That's a nerve. And I think there's another one here even better right here. Look what that is. Let me see if I can get the light right. This is a globus, singular globi, right in the nerve. Look at that. There's a nerve, and it's got 1,000 leprae organisms right there. So these will highlight on Fite stain, but also if you do a PAS stain, I found that PAS often stains mycobacteria too, not as brightly as fungus, and the shape of them you can tell easily they're not fungus. But usually the only time you're going to see that is on a case like this with florid. And see, look, here's another globus here, globus there. All of that stuff in the middle, that's all organism there. So pretty dramatic example. And also in the background, in addition to the histiocytes, there are plasma cells scattered in here. And I've seen that several times where plasma cells plus a granulomatous infiltrate was the clue to infection. I saw that once with a case of leprosy. I saw that with a case of mycobacterial pseudotumor from presumably from atypical, non-tuberculous, non-leprae mycobacteria. So when I see plasma cells plus granulomas, I often think of infection because I've had that as a clue several times. Now, we got very lucky that the person who shared this kindly also submitted a Fite stain. Look at that. They're everywhere. See them? They're so numerous. I wish I don't usually use a high dry and I never use oil personally, but that is one time where it's really good is to get these little tiny organisms, little tiny red acid fast bacilli, and right here they're in the middle of the nerve. Incredible, huh? So Fite Verruciform of AFB does this. I think this is actually the Fite stain, which picks up the leopard organism. So that's in Dermpath. That's the AFB that I basically always use as Fite stain. Or auramine rhodamine, which I've only recently started using and actually works quite well. I've never yet seen a case of leprosy on auramine rhodamine, but it works really well so far in my experience for other mycobacteria if you have a fluorescent scope. Look at that. Incredible. Okay. I really am fascinated by leprosy, and I've seen it a good couple handfuls of times, not nearly as often as my colleagues in other countries where it's endemic, but let's see, where's the skin here? Oh, maybe there is no skin. Nope. It's just a nodule here in the deep dermis and into the subcutis. You've got the fat replaced by something, a lot of stuff in here. So thinking about a tumor that's infiltrating the fat or thinking about a paniculitis, both a good idea. I'll go a little closer. See, it's like filling the spaces between the reticular collagen and leaving the collagen kind of intact. It's just like filling the spaces and expanding them. The lower power, I think, is pretty helpful. That could be lymphocytes or something heme, right? So when I see cells, a cellular infiltrate that's kind of diffuse, discohesive sheets, and it's filling spaces between the collagen bundles, I always first thought is a hematopoietic malignancy, right? Leukemia, lymphoma, myeloma, blastic plasmacytoid dendritic cell, which to me microscopically looks just like leukemia cutis. This case ended up being acute myeloid leukemia with monocytic derivation. And the cells are very atypical. They have abundant cytoplasm, which goes with a lot of the times when we see acute myeloid leukemia in the skin. It's usually monocytic or myelomonocytic, and it's those monocytic cells. Monocytes are the precursors of macrophages. And as macrophages and histiocytes like to get into the skin and into tissue, their precursor cells have that same potential and predilection to want to infiltrate into the tissue. So these malignant monocytic cells are crawling out of the vessels and into the tissue and filling in the spaces, just like we would see histiocytes and macrophages do in the normal setting. So, and just like histiocytes and macrophages have abundant cytoplasm that's pale, so do the malignant monocytic myelomonocytic precursor cells here. So they're very atypical. But lymphomas like diffuse large B-cell lymphomas and some other types of lymphomas could also have abundant cytoplasm like this. Many times lymphomas have less cytoplasm, but there are some that have abundant cytoplasm, like some diffuse large B cells and anaplastic large cell lymphoma. But I think for me, when I see this pattern in the dermis, the first thing I think is leukemia cutis. I feel like most of the time when I see that infiltration, filling the space and pushing apart, but leaving intact still the reticular collagen metals, it's not wiping it out. It's just filling the space in between. The most common thing I've seen that in is acute myeloid leukemia, but I have, again, occasionally seen that in other things too, like lymphomas and occasionally myeloma. So you would do immunostains here, and that's a longer discussion of what immunostains to do because there's not a perfect stain for acute myeloid leukemia in the skin. A lot of times the blast markers like CD117 are negative. In this case, I think it was positive for myeloperoxidase and a variety of others, but and this mass was the presenting sign of the acute myeloid leukemia. Then when they went and checked the patient's blood by flow cytometry and the marrow, they also had a leukemia there. So occasionally acute myeloid leukemia can present with leukemia cutis as the presenting sign, and very rarely, I've seen a couple cases, the patients can have leukemia cutis with no evidence of systemic leukemia, although of course those patients need to be followed very closely to make sure they don't develop obvious leukemia in the blood or marrow at a later time. And this case also infiltrates down into the subcutis. I think this was actually thought to be a cyst clinically, and this was shared with me from my very first Dermpath fellow, Dr. Hilary Elwood, who is an absolutely wonderful fellow and a great, amazing person to have as a fellow for my very first year in practice. So Hilly, if you're watching this, we think you're awesome, and I appreciate this great case. So, yeah, here, though, you could also think of paniculitic, subacute, subcutaneous paniculitis-like lymphoma at low power, which is alpha-beta lymphoma, or you could think of gamma-delta. Closer up, it doesn't have the beanbag cells or the rimming of adipocytes, but certainly you could think of that at low power if you just had the subcutis. So much more often when I see leukemia cutis, I get a punch, and the patient has multiple lesions, and they have known leukemia, and you guys as derms are biopsying it with the idea of rule out leukemia cutis or sweet syndrome or infection or something else. So that's much more often what I see is this pattern right here in the dermis on a punch biopsy. I only rarely have I gotten to see it infiltrate the subcutis like this. So. Right, what's this pattern? There's kind of a zone of necrosis here, and then around it, we've got some giant cells and histiocytes and little aggregates, so granulomas, right? So we've got granulomas. Some of them are a little bit sarcoid looking, but then here we have abundant kind of necrosis and breakdown of the fat. So obviously this is going to be infection until proven otherwise, right? I polarized it. There was nothing polarizable here. You know, you could think of other things in the differential, but we got to exclude infection first. And this case on culture was Mycobacterium kansasii. So atypical mycobacteria. Tuberculosis could produce a similar appearance, although I've never personally in real life seen a case of cutaneous tuberculosis, which just goes to show how very much we've worked to diminish the incidence of tuberculosis in the United States. But I know other people in the world see tuberculosis like almost daily, which is kind of shocking that in 8 years of, or in almost 9 years of practice, I've never seen one real case of tuberculosis in the skin in my practice setting. So remember that the prevalence of a disease in a population really makes a big difference for affecting your pretest probability when you're looking at specimens. And here there are streaks through the tissue, so also I would right away think of foreign body granulomas too when I see that. But when like I said, when I polarized that, I didn't see anything, so that may have just been a coincidental artifact. So this was Mycobacterium kansasii, atypical mycobacterial infection, which is what actually the mycobacterium I see the most often is in the extremities of elderly patients and in various forms of atypical mycobacteria, non-tuberculous, non-leprae. Anyone recognize this? Excellent. Once you've seen it, and it's a classic case, these are slam dunk, myofibroma. Now, in real life, sometimes they have some weird appearance, but you get these pink or often kind of light blue nodules that are called myeloid nodules. Sometimes I feel like most often they're bluer, not pink, and they look almost chondroid, so I like to call them pseudochondroid nodules. But this one actually looks more myeloid, so they're kind of spindle cells swirled around here, and they're actually like myofibroblastic cells. And then in between, you get zones that are more cellular. So it's a biphasic tumor at low power, right? Hypocellular nodules, more cellular zones in between the nodules. The cellular zones are bland, round to spindle cells. You can have mitoses in these, sometimes abundant. You can even sometimes get some necrosis. You should not see pleomorphism. That should really, make you stop and rethink the diagnosis if you see significant pleomorphism. These are usually bland, but they can have mitoses. And then classically, dilated branching staghorn vessels or so-called hemangioparasitic vascular pattern. So that combo together is good. Now, this patient was, 70 years old. Is that a problem? No. You can totally have myofibromas in elderly patients. They're more common in kids, but I've seen them many times in adults, even elderly adults. And these are benign. And even if they have positive margins, they usually do not recur. It seems like I've seen it once. I think that I had one that recurred, but they sometimes regress on their own spontaneously. So myofibroma, benign and beautiful. Oh, there's a nice dilated branching staghorn vessels there at the edge. Look at that. Very nice. Okay. Looks like normal acral skin, right? No inflammation to speak of. So we know the problem is probably going to be either they didn't get the lesion in the biopsy or it's something hiding in the corneum. See if I can get it to show up here. All right. Now it's a little hard with the camera to show, but you can, I think, tell that these are fungal organisms, but they are brown. See? That's not your imagination. They really do have some brown coloration in the walls of the fungal hyphae. So what is this? Yeah, Tinea nigra, which is a form of dermatiaceous pigmented fungi that actually make melanin. And another thing I learned from Dirk Elston, that a variety of fungal organisms make melanin or melanin-like substances, and sometimes they don't show those. They're not always brown, so there are other fungi that can make melanin too, aside from just the dermatiaceous pigmented ones, which I thought was pretty cool. I've learned an awful lot from Dirk's lectures over the years. He's an excellent teacher and just knows, well, everything, it seems like. So maybe one day I can grow up and be like that, but probably not. So I'm trying to set my expectations now so that I'm not disappointed when I get old. All right, so there you go. This is Tinea nigra, and variety of different dermatiaceous soil-dwelling pigmented fungi can cause this. The incidence of those depends on where you are in the world. I've never yet seen a case of this in real-life practice, and I've been looking because I love fungal things and infectious diseases. I'm fascinated by them, but I have never encountered one of these yet. So maybe one day. But the ones I've seen from recut sets and study slides that people have sent me, most of the ones I've seen were like this. They had like basically no inflammation, just a fungus growing in the corneal layer. So keep that in mind, that just like dermatophytes sometimes have no inflammation, Tinea nigra also. And I feel like even though they're brown, you have to look closer. And then once you see them, they're everywhere, but you have to kind of look close for them. Just a boring old cyst, huh? Okay, next case. Wait. Not so boring after all. What is it? Any takers?
Ochronosis.
Yeah, ochranosis. So don't stop at one diagnosis. Always check. I try to always look at, if I got a cyst, I check the epidermis to make sure I'm not missing, a melanoma in situ over top or something. So far, I've not found that, but I'm always looking, is there something else? Because I'm paranoid about missing the second thing. And here, the second thing is not necessarily really super important, but it's definitely cool to look at, and may actually be problematic for the patient because it's causing their skin to look unusual. But those are the brown bananas, right? The pigmented fibers in the dermis here. And I feel like you can see the pigment on both elastic fibers and sometimes on collagen. And this is nice and thick, but I've also seen ochronosis on small little fibers. So this is like the classic textbook view, but I have seen cases that were much more subtle. And this patient actually, it turns out, was using a topical hydroquinone cream, and that's what ended up causing this. So this was not due to alkaptonuria, which is the kind of primary endogenous form of ochronosis. This was secondary exogenous ochronosis related to hydroquinone cream application. And you can see that kind of yellowish brown color and the kind of curved banana shaped, if you like that, fibers there. Very classic example, ochronosis plus a cyst. And there's more of it up there, see? It's everywhere. Probably the most dramatic example I've seen in my practice so far. All right. So what is this? From 2X. Very good. Mixed tumor. You've got channels, ducts, tubules, cystic spaces, and then in the background, this stroma that can have a bunch of different appearances. Myxoid, it can have true cartilage, true bone, kind of slightly chondromyxoid stuff. It can have fat. It can be dense and fibrotic. But the one thing about it is a stroma that you can tell belongs to the tumor and is not background, right? I've got it upside down, but here's the epidermis here, and here's the dermis, and you can see the dermis stops there, and that's where the tumor starts. The stroma surrounding the epithelial structures is very distinct, and I find that to be the more characteristic feature. So chondroid syringoma is the other name for these, but I don't love that name because many times they're not chondroid. Now, this one has a little bit of chondroid area, and they don't really, to me, usually look like syringoma. They have these much more elongated branching kind of ducts, which can be lined by kind of flattened cuboidal cells or columnar cells. They can sometimes have apocrine snouts. Sometimes you can see hair follicle differentiation, keratin-filled cysts, a bunch of stuff. There's a little bit of cartilage there, just a tiny little smidgen of it. And then here we've got this kind of myxoid stroma. And these are tumors that have both epithelial and myoepithelial components. So if you do a stain, myoepithelial cells, remember, stain with not just with myoepithelial markers, but also with S100. So sometimes when the myoepithelial component is really abundant and people do an S100 stain, they can get concerned. I've seen one that was completely myoepithelial except for a few little ducts, and it was actually misdiagnosed as a melanoma because it had kind of larger rhabdoid cells and it was S100 diffusely positive. But then on review, it had a few ducts in it, and I saw that long ago, and it was a good lesson to learn. So, and if you see an adnexal tumor and you're not sure what to call it, the two things to think of is mixed tumor or hydradnoma, because both of those tumors have a wide range of different morphologies, and each one looks a little different. Now, this is not just a mixed tumor, but we get a bonus here. Look at this. What is going on over here? Ghost cells. Very good. Ghost or shadow keratinocytes. Little sheets where you can tell they used to be keratinocytes and they just died out, and then you've got giant cell reaction around it. And then over here we've got some cystic areas with blue matrical cells, and actually even a little inner root sheath component, a touch, which is, he's got like some little red trichohyalin granules in here. Crazy. So I've never seen one like this before. And this was, again, from a recut club. I think Omar Sangüesa, really awesome Dermpath, submitted this one. So this is a mixed tumor plus areas of pilomatricoma. I think that they are not colliding, but kind of arising from the same thing, but I've never seen that. I think you could even make an argument that it's almost like got some panfolliculoma sort of features here, and part of panfolliculoma can recapitulate all of the different aspects of the follicle. So I don't know exactly how to classify it, but I think it looks most like pilomatricoma, and then here clearly mixed tumor. I have seen mixed tumors with areas that look like trichoepithelioma or trichoblastoma, but I've never seen one like this, which is really cool, that has areas that really look like matrical. So I've never seen a matrical differentiation in a mixed tumor, but that is pretty awesome and wild. So Omar, thanks for sharing this really cool case. Right, just a few left here. Try to get the light right, okay. Okay, what do you think? It does look like kind of paisley tie, actually. And we'll reward that answer with a closer look. This slide's just a touch dark. And my camera sometimes mixed up a little bit darker. MAC is a good idea because you've got infiltrative tubules and ducts, but the problem I have with MAC is, let me go on high power here, cytologically, we've got pleomorphism, hyperchromasia, pretty ugly cells cytologically, but nasty, ugly, high-grade looking cells. So MAC is usually very bland, right? It usually cytologically looks benign. If you see something that looks like MAC architecturally, microcystic adnexal carcinoma infiltrating ducts and cords, but it looks malignant cytologically, it's probably not MAC. All the MAC I've ever seen has been very, very bland and looks almost like benign sweat ducts, except that it's, infiltrating nerves and skeletal muscle and stuff. So here we have ugly cells making nests. They're even focally in the epidermis here. So to me, when I see malignant cells making ducts or glands, that's an adenocarcinoma, right? It's a carcinoma of glandular or ductal derivation. The question now becomes, does this belong to the skin, or is this spread here from somewhere else? And in this case, this is metastasis. If you needed to know if you thought this could be, to me, the morphology of this doesn't look like any of the skin carcinomas or sweat gland carcinomas that I've seen. But you know, sometimes there are weird, you know, eccrine and apocrine derived carcinomas that can have a variety of different looks. So if you wanted to know, the best stain usually to do is a P63 or a P40, which are kind of very closely related. They're going to be positive in the majority of adnexal-derived neoplasms, both benign and malignant. Exceptions are a lot of apocrine carcinomas are negative for P63 and P40, and mucinous carcinomas of the skin usually are. But most of the other things, benign and malignant, of skin epithelial origin, both from the epidermis, squames, and basals, and also from adnexa, are usually positive for P40 and P63, whereas most metastatic adenocarcinomas from visceral organ primary sites are usually negative. Lung adenos are sometimes P63 positive, but much less likely to be P40 positive, which is why I kind of like P40 better than P63 now, and I feel like it's a little bit crisper. Here we've got perineural invasion even, and so this is one where this is metastatic adenocarcinoma. You got to work the patient up, check their history, find out what the primary was, and this patient had lung cancer. So this is metastatic adenocarcinoma from a lung primary, but you can think of breast, pancreatic, gastrointestinal. I mean, a lot of different primary sites. Really, you could do stains, and those can help point the direction, but in the end, they usually have to correlate with the patient's history, and if there's none, imaging studies. And imaging studies on this patient found a lung mass, and so this was a metastatic adeno from the lung, and I think it was on the scalp in this case. And I will point out that usually we talk about when the epidermis is involved, that means, like, you know, that the tumor is coming from the skin. Like when we see melanoma with an in situ component, usually it means it's a primary at that site. But sometimes melanomas can metastasize and grow up into the skin. We call that epidermotropic metastasis. They can grow up in the epidermis and mimic a primary. Carcinomas can occasionally do the same things. So here's metastatic lung cancer that's growing into the epidermis and could make you think, is this, you know, Paget's or some other carcinoma from the skin that's invading the dermis. Here, the vast majority is in the dermis, and there's only focal involvement of the epidermis. And again, it doesn't look morphologically to me like any of the normal skin primaries, so metastatic adenocarcinoma. Very unfortunate. And that other side was florid, but I would like to just briefly point out before we go to the next couple final cases is look at this. Sometimes it's very subtle. See there? Just a little bit of tumor cells. There. A little bit right there. That's why particularly when there's concern for like inflammatory breast cancer or something like that, metastatic carcinoma of the skin, look really closely, because sometimes you just little foci doing deeper levels can help. It can be real easy to overlook those if you're not very cautious. All right. We'll go quickly through the last 3 slides. Here's a cyst. It's got debris in it, keratin debris, and calcifications, which I think is just kind of coincidental, probably related to the debris. The lining almost looks stratified squamous, but it's kind of a little different, right? A little pale, like kind of like squamous mucosa. This is on the ventral penile shaft. So now what's the diagnosis? The midline, I'll point out. Yeah, this is a median raphe cyst. And really the key, I think, to making the diagnosis of these is the location, right? They are on the midline ventral surface of the penis, somewhere between the glands and the base of the penis. And it's the idea is that this is kind of a embryologic remnant left behind when the 2 folds close together to make the penile shaft. And the lining can vary. Here, I feel like this looks kind of like urothelial lining, or in the olden days called transitional cell lining. It looks kind of like stratified squamous, but a little bit more pale and kind of bulging and bubbling at the top. But they also can have other linings. Here's a second example. Both of these from Dr. Mike Hitchcock, who's a really awesome dermpath. who I've had the pleasure of knowing through working with the American Society of Dermpath in the past. And here's another evidence that when you see a ton of little tiny nerves right in the dermis, always think about glans penis or the area around the clitoris. Those areas have a very rich innervation of lots of small nerves in the superficial dermis even. And here's one, and look, there's some sebaceous glands, so that would be called a Fordyce spot, right, which is basically a normal anatomic variant, those little whitish yellow papules that can be in the genitals, both male and female. And here we've got some cysts that have like kind of double layer columnar or cuboidal lining. And then over here on this side, you can see that same thing, much more cystic. These areas are lined by urothelium with nice umbrella cells at the top. See these large cells up top? Those are like the umbrella cells that kind of cap the surface of the urothelial lining, like in the bladder and the urethra. And then down here, it transitions to kind of more double cuboidal to columnar lining. So two different examples. And I mean, here almost looks like ciliated, right? Almost cutaneous ciliated cyst looking. So the key to me is really the location for a median raphe cyst. It's got to be in the ventral midline penis, I think, to be a median raphe cyst. Something I don't see very often in practice. And then finally, one last one, and then we'll go for the day. What's this? Yeah, very nice glomus tumor. Perfectly round, monotonous little cells. Very well demarcated cell borders, usually because each cell is wrapped around by a layer of basement membrane. And they kind of run in these these little rows or kind of linear structures that wrap around the vessels. See how they're kind of arranged in little lines here. So people sometimes call it onion skinning, but we use that word too much. I would say that, neuroendocrine tumors can have a pretty similar appearance sometimes to this. So if you had, like, this area looks almost a little nested, has kind of a little speckled salt and pepper chromatin, I would not fault someone for doing keratin or endocrine markers on these. And they do tend to do this where they kind of wrap and make these rows around the vessels. So glomus tumor, and if you have abundant vessels, you can call it glomangioma, but really the distinction is usually not of clinical significance, although there are some syndromes, glomus syndromes, where patients have multiple lesions, and those patients usually have glomangiomas rather than the solid glomus tumors, but otherwise, basically, these exist on a spectrum. So, and what stain would stain this? Typically, what would this stain like? What are glomus cells basically derived from?
Like the modified smooth muscle around a vessel?
Exactly, Dr. Pitch. They are modified smooth muscle cells, modified pericytes, basically. So they stain with smooth muscle actin and usually negative for desmin, and they're going to be negative for endothelial markers like ERG or CD34 or CD31 usually, because they're not endothelial derived. The vessels have their own lining of endothelial cells, and these tumor cells are from outside the vessel, not inside. So occasionally I see residents get confused about that, especially in the glomangiomas, because they have a bunch of vessels and they'll think, oh, it's a vascular thing. No, it's just a tumor that has a lot of vessels in it. The tumor cells are actually from the outer edge of the vessel. So in any case, nice glomus tumor. All right, guys, I think that's everything. Enjoy your Thursday.